Hello, my name is Sean Kennedy. I'm the Director of Health Information Exchange for the Massachusetts eHealth Institute, and today I'd like to share with you the apples and oranges of HIE. Well, I'm going to start by briefly working to detangle a sampling of the myriad of organizations in this HIE space. We're in a dynamic market with organizations taking shape to address the variety of opportunities HIE presents, like building trust, ensuring conformance to standards, establishing information pathways. While I slotted organizations and efforts into categories, few fit so neatly into one category. Starting with collaborations, these organizations grew out of a need to more easily exchange information. If you've not lived with this yet, you will. It takes at least two to dance in the world of HIE, a sender and a receiver. So it is natural that groupings of organizations would rise to tackle the numerous barriers that exist or to take advantage of the emerging market. The Care Connectivity Consortium is a collaboration among provider organizations, Geisinger Health System, Group Health Cooperative, Intermountain Healthcare, Kaiser Permanente, Mayo Clinic, and Oregon Health Information Network, in collaboration with Healthy Way to develop and incubate new capabilities for consideration and adoption by eHealth exchange participants and the broader HIE community. They provide patient matching, record locator service, consent management, and integration services. Where the Care Connectivity Consortium is comprised primarily of provider organizations, Commonwealth is comprised primarily of EHR vendors, such as Allscripts, Athena Health, Cerner, CPSI, Greenway, McKesson, and Sunquist, and aim to tackle the problem of interoperability of EHRs. They provide patient linking and matching, patient access and consent management, record locator services, and directed query services. Care Equality, while a collaboration, does not offer a set of technical HIE services. Rather, they are an action-oriented collaborative that aims to build upon existing exchange capabilities, leveraging existing standards and agreeing upon innovative approaches to improve exchange workflows and adoption. Similar to how banks came together to grow the adoption of ATM networks, they aspire to do the same for HIE and healthcare. Moving to the trust quadrant, Direct Trust maintains a national security and trust framework in support of direct exchange and is made up of over 120 representatives covering HISPs, HIEs, certificate authorities, consultants, state agencies, EHR vendors, and provider organizations. They offer a trust bundle service, essentially a way to scale trusted exchange for accredited organizations. In a related manner, the National Association for Trusted Exchange, or NATE, developed a scalable trust and policy framework that is intended to eliminate the existing barriers inhibiting the use of health information exchange. Different than Direct Trust, their membership is primarily, but not exclusively, made up of states: Alaska, California, Florida, Hawaii, Missouri, Nevada, North Dakota, Utah, Oregon, to name a few of them. They also provide a trust bundle, among other services, to facilitate trusted exchange. Scooting down to the HIE box, Healthy Way is a nonprofit spun out of ONC to manage the eHealth exchange, a trusted, secure, nationwide HIE with shared governance and necessary shared services for organizations who wish to connect with a network of networks. They have thousands of providers connected and provide a gateway for exchange with participating federal government agencies. Similarly, the Mass Highways are HIE on the state level. This is a public exchange funded primarily out of federal funding, but also through state matches, and then also through contributions through membership fees. eLINC and Wellport HIE are private regional exchanges that exist here in Massachusetts, and collectively eLINC and Wellport can connect into the Mass Highway, and then ultimately all of them could connect into eHealth exchange to really become a network of networks supporting cross-nation exchange of information. In wrapping up on the certification and accreditation category, these two bodies work to promote consistency in the market by certifying or accrediting issuers of digital certificates. Federal Bridges is the federal government's common infrastructure to administer digital certificates and public keys, including the ability to issue, maintain, and revoke public key certificates. The term Federal Bridges Cross-Certified implies a HISP conforms to the Federal Bridges Certification Authority requirements. The Electronic Healthcare Network Accreditation Commission aims to achieve quality and trust in health information exchange by accrediting HISPs, CAs, RAs, and HIEs through the various accreditation programs like HIEAP and DTAP for HISPs. This is a dynamic and remarkably confusing environment. The key takeaway is that all work together to enable trusted, secure, scalable. And today I'm going to share with you a few facts and figures on the national and Massachusetts level in statistics around health information exchange. Based on a 2012 survey, there are roughly 280 HIEs, some public, some private, and as of today, likely a few less. Regardless of how many HIEs there are, adoption is clearly on the rise. 1/2 of the nation's hospitals are now participating in a regional, state, or private HIE, and 71% plan to buy new HIE technology next 2 years. Furthermore, nearly 1/2 of the nation's physicians plan to join an HIE survey. In this one, 4 in 10 hospitals, or 41%, report an exchange capability for patient health information to and from external sources. Further, 51% of hospitals can query from external sources, which is an uptick from 38% in 2012. Moving to Massachusetts, here at MeHI, we recently conducted a survey of Massachusetts-based provider organizations. While this data is self-reported from practice managers, it provides a reasonable estimate of HIE adoption among Massachusetts-based provider organizations. It is reported that over 26% of Massachusetts healthcare practices participate in an HIE. Of that 26%, 51% are participating in the Highway or other private exchanges, including Wellport, Holyoke, Connect, and eLINC. However, a number of practices that reported participating in HIE could not name the exchange in which they were participating, indicating that these exchanges may not be well known. Of those 26% that indicated they are participating in HIE, here's how they said they were using it. 77% said they were doing it for public health and quality measures, 75% for requests for referral, 74% for e-prescribing. Then getting down to the next tier, lab and test ordering was 45%, eligibility verification 39%, transitions of care roughly 28%, and then down from there. So specific to the Highway, our public statewide health information exchange, organizations are joining and transactions are happening. This represents activity from April, where we had over 200,000 transactions exchanged through the end of April. And cumulatively, from inception to date, which was October 2012 through April, we're at almost 2.5 million transactions. We have roughly 200 organizations contracted to join the Highway, with 105 of them currently connected. This Highway status map, while in development, graphically shows who is participating in the Highway and provides a sense of their progress. We've got these statuses we name as in progress, connected, and transacting. Our goal is to get a lot of green dots out there. The more green dots, presumably the more valuable the HIE becomes due to more trading partners. And what we very much want to do is to maintain a library of ways people are using the Highway in an effort to grow adoption. You can see a sample of what we're thinking with this Milford example, where we show the organization name, Milford Regional Medical Center. Their status is transacting, and you can see the corresponding green dot. You can see their city, street, and then you can see a summary of their use case. So let's scoot over to HIE drivers, challenges, and trends. So from a driver's perspective, here's a sampling of some of the drivers. It certainly isn't all of them, but you know, if you want to receive incentive payments, you need to align to meaningful use objectives and the certification criteria. It's certainly been the biggest driver in the market. Meaningful use 2 has got a big HIE requirements for some of the objectives, so that's a big driver out there. ONC grant funding to promote adoption of HIE and EHRs. A lot of grant funding over the last couple of years. The RECs, the state HIE program, and then the Beacon communities were certainly big pots of money that motivated a lot of activity in the market. There's also new shared risk and shared reward healthcare reimbursement models that require the sharing of data. This is something that most of you, I suspect, are quite intimately aware of. And then there's a lot of the patient safety concerns. So this is a study from 2004 funded by the Commonwealth Fund and conducted out of Duke entitled Electronic Medical Records, Getting It Right and Going to Scale, where they cite a number of examples where the lack of information leads to patient safety or care coordination concerns. So the first one there, physicians sharing the same patient ordered duplicate tests and therapies. The same drug and radiology exam were ordered 11% of the time. Physicians did not know what other physicians were doing to their patients. They say that primary care physicians were not aware of 1 of 4 prescriptions taken by patients. And uncertainty and hassle drove a lot of decisions out there. So that last sentence, 1 in 5 lab and x-ray tests were duplicates because of retrieval barriers. So presumably making information more available at the point of care could reduce some of these findings. And then we have a number of drivers here locally in Massachusetts. So I'm sure everyone's familiar with the 2017 mandate that's out there where it says all providers able to access an EHR network through the statewide HIE. I suspect that's certainly motivating some activity. And then Chapter 224, cost containment provisions. This is actually a graphic that comes out of the 2013 Mass Cost Trends report published by the Health Policy Commission. And they basically show that Massachusetts is a big spender of healthcare. I suspect many of us knew that. We're actually number 1 in the nation for per capita spending, roughly 36% above the national average. So they did a deeper analysis to understand some of the inefficiencies that may be present in that $9,200. And they came up with 5 categories that are contributing to wasteful spending here in Massachusetts. Now, HIE certainly can't address all of them, but we suspect for that failures of care coordination, there's really an opportunity for HIE to come in and do some effort, and I suspect is driving some of that activity. So if you read the description of avoidable spending due to communication failures and lack of care integration across settings, resulting in roughly $700 million in avoidable spending. So certainly a nice opportunity there. The need for HIE is clear, but it's not a smooth road ahead. So many of you know Mickey Trapassi. He's the CIO Mass eHealth Collaborative. He did a nice interview where he described that workflow and ecosystem maturity are the biggest challenges to meeting the transition of care and view, download, transmit objectives of Meaningful Use 2. 2 of the roughly 6 groupings of objectives with an HIE component. While organizations are gaining great experience connecting to HIEs, there really remains little implementation guidance. Frequently, the documentation lags product availability. Well-funded HIEs in the days of the ONC grants, they could get by without the well-defined value proposition, but now that we're in the area of sustainability, a solid value proposition is an imperative. Is the value the HIE proposes more than the effort and funding required to change workflows, build technical connections, and invest in staffing resources? From a HIS perspective, getting different secure networks to talk to one another, it's a hard nut to crack. Working then to be able to share directories certainly further complicates the problem. And these are some pretty big prevalent issues that we're working through right now. As we advance toward interoperability, ensuring exchange data is usable by the receiver is certainly a big deal. And I love this quote, you can't draw a border and say patients stop here. This was from Dr. Overidge, who's the Chief Medical Informatics Officer at Siemens, where he's describing how HIEs frequently are forced to end at state borders. There was a study put out by the eHealth Institute back in 2013, just last year, where they talked about a number of the challenges they see in the market. Here's just a couple of them. Interoperability, clearly getting to interoperability without the steep interface costs and making it more plug and play is of interest. Financial sustainability, there's still this big tension between public and private financing and finding that right balance for sustainability. A lot of competitive exchanges, a lot of competitive concerns exist out there. This idea of exchanges frequently are limited to exchange within an organization and their affiliates. Much fewer are exchanging with external organizations or unaffiliated organizations. And then finally, patient engagement certainly remains low across the board. So from a trends perspective, from exchange to interoperability, interoperability being transport, content, vocabulary code sets, The S&I initiative has been diligently working to ensure we're not just moving data around, but we're trending toward creating interoperable solutions. There's a lot of effort being put into transitioning from fee-for-service to value-based payment models. This move of quality over quantity translates into participation incentive programs like meaningful use, like ACOs, patient-centered medical homes. And the success of these new payment and delivery models depends on their capability to gather and analyze clinical and claims data, report on quality measures, and provide actionable information in support of improving care and outcomes for individual populations. There's this another trend that's perhaps not as positive, but it's an upward trend, is that adoption of EHRs certainly is outpacing HIE adoption. HIEs went from 14% back in 2010 to 30% in 2012 to 41% today, whereas EHRs moved from 19% to 2010 to 56% in 2012, and we're now over 78% adoption of EHRs nationally. And if you haven't felt it yet, consumers are coming. So in this Deloitte study, they described that the majority of consumers really want access to tools, websites and rankings, patients' reviews of doctors and hospitals. Patients now routinely ask, do you have an EHR? May they soon ask, are you connected to an HIE? So let's end here with more about what's ahead. HIEs are going to get easier. I feel quite confident. I'm living in this world, and just in the last 2 years that I've been working on this, I've seen a lot of learning go on. So EHRs are certainly starting to get there. The experience in the market is growing. Trust is being established, which is going to open all kinds of pathways for information exchange. As more organizations join HIEs and more information is exchanged and more use cases are born, the value of the exchanges will continue to grow. IOM recently published their recommended domains of social and behavioral data to facilitate organized capture in EHRs. There's clearly this this thirst for this type of data among providers, and with the new recommendations from the Privacy and Security Tiger team, I think just came out yesterday or the day before, to tag such data to enable deeper data segmentation of EHR data, this may soon come to pass. And then how do you analyze data sets that are not aggregated in one location? This concept of distributed analytics allowing for kind of federated queries is certainly being considered. And then finally, interoperability. ONC released their 10-year vision for interoperability, where they described the health IT ecosystem. They painted a nice vision for interoperability, offered some guidance or guiding principles and agendas for kind of the 3, 6, and 10-year marks, ultimately evolving the nation into this learning health system. And they also offered a number of building blocks to really getting us there. And this is kind of a transition to our guest speakers. This is kind of the final trend out there, but they really reflect this trend of the rise of private HIEs. So in general, private funded HIEs are growing at a much faster rate than publicly funded ones. From 2010 to 11, the number of live public exchanges doubled from 37 to 67, whereas the number of private exchanges tripled from 52 to 161. So pretty significant increase, and certainly a topic that we want to learn more about. I'm going to go ahead and introduce to you Eddy Rospide, and I'll transition this over to him. Eddy is the EMR HIE Director at Winchester Highland Management, where he has tirelessly worked to help build the Winchester Highland Management and eLINC connections to the highway. Prior to joining Winchester, Eddy served as a Director of Information Systems, Data Integration Services at Albany Medical Center, and prior to that, he was a Director of Professional Services at WellLogic. Of note, Winchester Highland Management is one of our 32 highway implementation grantees, and with that, I'll go ahead and allow Eddy to share his presentation with you.
Our HIE basically was formed between Winchester Hospital and the IPA. The IPA here in the community, it's an independent practice association, is made up of almost 400 physicians across the community. If you want to learn a little bit more about us, you can go to that link. This is our test website that we just published this past week. And what eLINC stands for is to electronically leveraging information, improving care, networking providers and communicating with each other. We see this HIE as a vehicle for providers to message each other, share and exchange information in a secure, safe, and non-competitive manner. And that's really key here, non-competitive manner, okay? The same folks that implemented the HM-supported EMRs, typically are working with our participants. But, this is, I want to actually explain, when a group joins eLINC, even though we are a business venture between both the Winchester Hospital and the IPA, the specific members of those organizations actually have to join the HIE separately, okay? They have to sign participation agreements. We have to work with them. We typically, our team is the same team that actually implemented the EMRs, that helped them with meaningful use attestation. So when one of those groups actually join our team, we make available to them secure, direct messaging accounts that they can use to communicate with each other. So our first preference is that the physicians or the clinicians communicate directly inside their EMR. If they cannot obtain a secure direct address from their EMR vendor, we can allocate them one, or we can forward them to the Mass State Highway. We also provide hospital admission and discharge notifications for primary care providers. So right now we have it available for our PCPs. Right now we have it set up for the ACO, the Winchester ACO, where if one of their patients on the list of ACO patients arrive at the hospital at DED, or they get discharged from DED or get admitted to the hospital, then the care managers at the ACO would get a notification, okay? And our physicians, we haven't published this well enough. Our physicians can actually register for this and provide a list of patients. So when I start talking about the use cases that we're working with Salter, we'll talk about how the next step that we're taking with this. Clinicians can access their clinical information, directly in their EMR. So when we talk about our eLINC HIE, what we're trying to do is make sure that clinicians are not going to log into a portal. We want to make it so that we integrate directly inside the EMR, which ends up giving us close to 100% adoption, because if it's integrated in their EMR, they're less likely to want to go somewhere else. They can actually access the information and make it an inherent part of their workflow. We also deliver results from Winchester hospitals, like lab results, radiology reports, as well as departmental reports from Winchester Hospital to any other IPA physicians directly in the EMR via HL7 interfaces. Later on, I'll talk more about some of the business intelligence services that we want to provide for the network for provider quality performance reporting to some of the networks or insurance companies that they have contracts with. Okay. So let me try to explain, trying to describe what our ecosystem looks like. I did say we have about 400 physicians, Winchester Hospital. Currently, out of those 400 physicians, there are 208 that are eligible physicians that have EMRs that have it tested for meaningful use stage 1, and we're diligently working with those providers to get them ready for stage 2. We have 81 interfaces between Winchester Hospital and those physician practices, and of those 400 physicians, some of which are required to actually have EMRs, we have 23 different EMRs in the community, okay? But we only support 11. So there are some practices, for example, an IVF, an in vitro fertilization site that may be using an EMR that is not meaningful use compliant because it's typically a cash-based business, and they don't typically implement meaningful use type of EMRs. So you're going to have a lot of systems out there that are not meaningful use compliant, okay? And of those 23, there are 11 that are currently supported, and they're listed right there: eClinicalWorks, Athena, Allscripts, NextTech, GE Centricity, Origin, Practice Partners, MD Intellisys, Viterra, NextGen, and Amazing Charts. 23 practices or 27 physicians currently are still on paper. So we are at like 87% EMR adoption, and we hope to complete these hopefully by the end of the year. But those are usually the holdouts. Those are the folks who are waiting until health freeze is over before they implement an EMR. So a lot of them are waiting to retire. Some may have gotten waivers, so they don't have to implement an EMR in the network until next year. So what are some of the use cases that we support? Originally, Winchester Highland Management had applied for, and thanks to the MeHI folks and the Mass State Highway, we received a grant that would allow Excel Orthopedics to send patient information to Winchester Home Care as part of the program for the joint surgery program over at Winchester Hospital. So what this program is where Excel is a big orthopedic practice. They send patients to Winchester Home Care who are going to have surgery at Winchester Home Care. And the key here is they're having joint and knee surgeries or hip surgeries that they would be discharged home as opposed to another healthcare organization. So thereby reducing costs, because with the patients going home, it reduces costs. So that's a really good use case. And then also Excel Orthopedics is using that same grant. Excel Orthopedics is actually communicating with the surgical pre-admission and testing folks, making sure that the surgical packages are ready to go. So that grant has been a godsend for us, where we've been able to actually deploy our HIS and then connected it to the Mass State Highway. Winchester Hospital is connected. The Winchester Home Care folks and the folks at the surgical pre-admission and testing are connected to the Mass State Highway. And the folks at Excel Orthopedics are on the eLINC Health Information Service Provider accounts. So they connect using eLINC Direct. They send messages directly to Winchester Home Care or Winchester Surgical Pre-Admission Testing to coordinate the care of that patient for that surgery, so that they can prevent the patient from being readmitted, and also of being admitted to another healthcare organization, and they want them to go home. Okay. So some of the upcoming activities that we're working on. Well, actually, before I move on, I want to actually we also work with Salter, another organization that's actually joined the HIE. That's a non-Winchester organization. They've joined our HIE, and they received a grant from the Mass State Highway. Working with us is to do the same exact thing. Salter is part of eLINC. They are communicating with the Winchester ED and the Medical Records Department. So when they send a patient to Winchester Hospital, to the ED, they electronically will send that information over to Winchester Hospital. And then Winchester Hospital would then, when that patient is getting discharged, they're going to send a CCD back to Salter Healthcare, okay, thereby coordinating care transition between the two organizations, okay? So some of the key activities that we're working on this year is really, we want to deploy secure messaging across the community. We want to continue working with our physicians to attest for MeFuse Stage 2. We want to deploy the clinical repository, which is what we call eLINC Clinical, to the community. So right now we're going to pilot this with 2 ECW practices by the end of the month, and we're also integrating Athena. So most of our practices are on Athena and ECW, although we have that list of 11 supported vendors. The majority of our EMRs are on ECW and Athena, and we are trying to build IHE type interfaces with those EMRs. So our solution for our clinical repository is the ECW EEHX solution. And if you really look at its features and capabilities, Meaningful Use has been really, really good to this platform. With the Stage 2 CCDs, what we're trying to do is, with the Stage 2, what we're trying to do is get CCDs from EMRs that are mean for you stage 2 compliant. So the software does support the C32 CCD integration. Documents can be uploaded directly from the ECW practices, and consent can flow directly from the ADT, directly from the integrated EMRs. So typically what we try to do with the EMRs is we have them capture the patient consent on the EMR, and then an ADT message along with the CCD at the end of the day, at the end of the encounter, would need to come to the HIE. So the model that we are implementing from an HIE standpoint is a centralized model where data from the EMRs will be uploaded to the HIE for access by folks within the community for patients who have given consent within the community. Now, our consent model is one that is community-wide, so the patient only needs to consent in one location, and then when that patient is being seen at another location, if they have an interface to the HIE, that physician will have access to that patient's record. Okay. Some other work that we have that we're working on in progress with our platform is really we want to make sure that physicians who don't have the native interface with the HIE can actually download an encrypted CCD. Because one of the key things that we want to make sure from a privacy security standpoint, if you download a CCD on a PC, that it's got a password associated with it, so for privacy and security. The patient consent capture, by participant staff, in cases where no ADT interface with consent exists between the participant, with the participant EMR and the HIE. Okay, so if there's no native interface where they're going to give us an ADT that says the patient gave consent, well, somebody has to log on to the HIE portal and say this patient gave consent, right? And then the other items is really more on monitoring performance and then workflow, and really the proper education of participants. So we have a lot of work to do. What we're trying to do, we have a very small team. What we're trying to do is roll out this solution across the community. We're ready to go. And our first two big pilots are going to be with ECW and Athena, and then after that we're going to roll it out to those. Once we test the interface, we're going to roll it out practice by practice, at least for those two EMRs, and then continue working with the other EMR vendors to pilot and then deploy within the same environment. So what I thought I'd do is actually give you guys, this diagram is actually a year old. It will be interesting to see whether it's consistent with some of the stuff that we've done. But basically, if you look at the diagram that we provided with our ecosystem, Winchester Hospital runs Meditech. And then here you have the eLINC platform, which comprises of EHX, the eLINC HIS, which is supported by Secure Exchange Solutions, and then Provider Exchange, as well as Summit for our integration engine. So what we're trying, and then on this side, we have a bunch of EMRs that we support. Right now, this list may be incomplete. I think what's missing on here is MD Intelisys. But basically, most of the IPA practices on these EMRs, and then most of the IPA practices have their own patient portal. So what we do right now is we deliver results from Winchester Hospital. So anything that connects to this box in the middle is the eLINC HIE. So we deliver results to those practices. And then at the end of the day, once a practice finishes seeing a patient, if they are a member of the HIE, clinical encounter information will flow from that EMR to EHX. And then one of the other projects that we are working with Winchester Hospital this summer is to actually take ambulatory orders and then send them to Winchester Hospital to help improve the workflow so that the order IDs now are closing the loop and making sure that the results that were, the tests that were ordered from Winchester Hospital are actually matching the order IDs. Then obviously we have the physicians doing secure messaging. Winchester Hospital is connected to the Mass State Highway, and the folks on the other side with the IPA practices, they're either connected to the EMR or the eLINC HIS, okay? And then there'll be most of them, most of these EMRs here can actually connect. So let's go down the list, for example. ECW, we've already tested with eClinicalWorks. So eLINC can send to ECW. We've tested sending production information from Winchester Hospital all the way to Athena. Next Tech has the same HIS as we do, so that's a non-issue. Practice Partners uses Relay Health, which is part of the Direct Trust, and the company that provides the services is part of the Direct Trust. GE Centricity, they use Cryptic, which is now related to SureScripts, and they're part of the Direct Trust. This company hasn't done its work yet. Allscripts is actually using MedAllies. MD Intellisys is actually using Secure Exchange Solutions. So those organizations, except for those EMR vendors, except for Origin and Vitera, they're actually using technologies that we either have connected to or they're part of the Direct Trust, which the company that we work with is connected to. So most of our providers here will be able to communicate with Winchester Hospital and with each other. So our goal is to allow them to actually to be able to communicate with each other and help improve the coordination of care. And then Winchester Hospital also is attesting for meaningful use, meaning that they need to send discharge CCDs out to the providers in the community as well, and that's on the way. And then eventually what we'd like to do is when the RLS query response piece with the Mass State Highway comes about, we want to act as the source for our participants for the Mass State Highway. Okay. The third piece to be determined is the connection with skilled nursing facilities, NEQA, which is a contracting company that is associated with the IPA. Winchester Home Care, which is actually a part of the grant, has already been done. So thanks, MeHI, for that. And then we want to connect both to Tufts Medical Center as well as eHealth. So with that, I think one of the things I want to make sure that folks understand, with our longitudinal patient record, providers have three different ways of getting into it. And I like the first one. No, actually, I like the third one the best, okay? You know, they basically access it to the EMR. There's no logging into anything. It's a direct interface right into the EMR. And the first two, those are for practices like, for example, Practice Partners, Origin, and Vitera, where the providers are not going to have a native interface that's IHE compliant into their EMR. So in that situation, then the provider would have to log in or use a magic button to get access to the HIE data from the community.
Let me just introduce Joe Heyman. Joe is a former chair of the American Medical Association Board of Trustees, former president of the Massachusetts Medical Society, and just finished a 3-year stint as chair of the National Physician Association Board of Optum Incorporated. He served on the Board of Commissioners of the Joint Commission and the Board of Directors of Joint Commission Resources International. He serves on 3 subcommittees for the Office of National Coordinator for Health Information Technology, the Bryan University Advisory Board, and the Advisory Board for Digital Collaboration Solutions. He is the founder, former president of the Chief Medical Information Officer of the Whittier IPA Incorporated, a nonprofit organization of physicians in Merrimack Valley that owns and operates the Wellport Health Information Exchange. He practiced obstetrics and in gynecology in both a group and solo practice for 41 years, having retired from clinical practice in March 2014. And with that, Joe, I welcome you, and please, I'll advance the slides for you.
So this is what we're doing. This is my mother-in-law. I have signed consent so that I can use her for display purposes. This is a longitudinal record that actually goes further over to the left, and it shows every encounter with the healthcare system, different practices. You can see the practice names at the top, and those little dots that you see there are progress notes. The bars are different problems, when they start, when they stop. If you went down further, which you can't on this because this is only a screenshot, and this is live actually, this is in our production environment, you would be able to see laboratory work. You would be from either Quest or from one of the hospitals that might be joining us. You'd be able to see x-ray results, vital signs, and if there were anything abnormal, you'd see a little red bar at the bottom to show that there was something abnormal below the screen. This is a typical progress note. This is not using EHX, but this one happens to come from a eClinicalWorks practice. This is done by extracting the HL7 information from the database at eClinicalWorks and then reformatting it into a progress note. We also do that from GE Centricity, and we also can, will be able to, we're in the process right now of doing this, be able to take something a little less detailed like a CDA from the eClinicalWorks SAS process practices. We can also generate a direct message and take anything that's on the exchange and attach that clinical information to an encrypted direct message and send it to another provider, either within the HIE or on the Mass Highway to another provider someplace else in the state. And you can take as much of that clinical information as you want, and you can actually remove, you can take clinical information from more than one practice and attach it to the same direct message. There's also a single patient portal, and this is how the patient sees it and signs in. And as you can see, they can schedule appointments, request medication refills, request referrals, create and manage personal health records, address insurance and billing issues, and communicate with their providers. All of this, of course, depends on whether their provider is willing to accept these kinds of messages. And here you can see, this is what the patient would see. We don't have any patients signed on yet, just physicians, and I'll explain that in a minute. But as you can see, they get a consolidated CDA, and they get a summary for every single clinical encounter that they wish to download a CDA for. They can do it by practice. So the motivation for doing this was the need to provide services and products for our members without attaching imprisoning requirements for them to have to be with a single network or a single hospital. We wanted to have clinical integration for contracting purposes and to avoid antitrust issues, and we had the wonderful opportunity of being able to be part of the Mass eHealth Collaborative. We were one of the communities that got a grant, and for that reason, all the physicians in our community have EMRs, hardware and software. Once again, the importance of physician independence so that they're not imprisoned. They can move from one type of practice mode to another. And this was way before ACOs, so we were just interested in improving the quality and efficiency of the care that we were providing. So after the Mass eHealth Collaborative, we actually were attached to a vendor, and things didn't quite work out. And unfortunately, the most important thing for us, which was establishing a health information exchange, didn't happen. Part of the reason for that, though, was that we had outrageous demands about what we expected from a health information exchange 5 years ago, and the truth of the matter is that we're just developing that sort of technology now. We've learned that you've got to keep it simple. During that 4 years that we've been up until a year ago, we have had experiences with 3 or 4 major vendors, and in each case we got very close but no cigar. For example, we had one vendor that couldn't produce a single reference who was using ECW. We had one very major vendor where we were about to actually sign, and then they told us we had to have a hospital as part of the network at the very beginning, which was one thing that the IPA was absolutely opposed to, because we have 4 or 5 major hospitals, well, they're community hospitals in our neighborhood, and we didn't want to have one hospital be part of this and then not be able to get any other hospital to sign on. And then we had one vendor that actually quadrupled the price on the very last day. And we finally signed with Alir this past summer, and that's working out very well. And let me just say that one of the reasons that our relationship with eLINC is working out well is because they were able to scale this to a small IPA like ours. And so as we get bigger, the amount that we pay eLINC gets larger. But at least it's affordable, and we have a sustainable business model for the next 5 years. So first of all, we have this chicken and egg problem in Massachusetts because we have an opt-in environment. And to get physicians to sign on when there are no patients signed on is a problem. And to get patients to sign on when there are no physicians signed on is a problem. So we've been marketing to physicians, and right now, as you'll see later, we have 41 physicians signed on. It's about 7 practices. And they are live, and they are sending data, but the only data they can look at is their own patients' data because none of the patients have opted in yet. We had to get access to the databases. We had to do the reformatting of the HL7 stuff. We have 17 different vendors, and we developed a mission and vision, and we created 3 committees to help us administer this program. And we had to produce lots and lots of important documents. This is our vision and mission, and it's pretty simple. It's all involving trust, and it's also trying to make it possible for anybody in any system. We have patients up here in the Merrimack Valley. Very few of them are in just LAHI or just Partners or just BI Deaconess. They're all in more than one system, and they don't even know what system they're in. So we want to cut across all of that, and we want to allow our physicians to see a really complete record, not just a record from one hospital or one system. These are our operating principles. As you can see, they say pretty much what I just said. And I'm sort of rushing through because there's so little time, but as you can see, we won't share any confidential business data unless somebody requests us to do so. We will not sell clinical data, and we're really sharing these purposes only for treatment, quality measurement, and improvement in public health. The advantages of an IPA ownership is that patients are used to having physicians be the stewards of their data. The ethical use of data for improvement of quality and efficiency rather than for some other third-party purpose. Instantaneous access to aggregated data, no physician imprisonment, potential income stream for the IPA. We are able to give direct addresses, and of course, as already mentioned, it helps with the meaningful use achievement. The advantages of a regional HIE are that clinicians can see all of the patients in the community, not just the ones in their own system or their own hospital. No silos, improves the health of the entire community, improves efficiency for the entire community, the ease of a referral, and the fact that a patient doesn't have to have 12 different patient portals. They can go to one place to see all their clinical information. The long-term advantage is that we can do quality measurement for the entire community, quality measurement for any subset of the community, and the potential addition of new innovative services. So right now we've got 43 physicians on production platform. We have 101,000 patients in the system now. We have 794,000 progress notes in the system, and we don't have a single patient opted in. So we've got the platform live and running, and we've got a few more practices we want to get on board before we start opting in patients. So we're planning on opting in our patients sometime about someplace between 3 and 6 weeks from now. And if you go to our website, which is www.wellporthealth.net, you can actually see the marketing documents and stuff like that that we're going to be using to opt in patients. And that's my information right there that you can take for if you ever have any questions or want to talk to us. And by the way, we're interested in moving beyond just the Merrimack Valley. If anybody else wants to join our HIE, especially another IPA that doesn't want to have to go through what we've had to go through, more than welcome to talk to us.